Welcome back to General Surgery Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. If you're attending virtually, you may enter your question into the Q&A section. A link to the event survey will then be shared in the chat toward the end of the program. For all of you here in person, please be sure you grab that little slip with the QR code. That'll take you to today's evaluation as well. And if you are ABS certified and want NGHS to report your CME credits to the American Board of Surgery, please fill out the evaluation and give us permission to do that. And now it is my pleasure to introduce our speaker. A Kansas native, Dr. Grabill received his undergraduate degree from the Emporia State University in Kansas, graduating magna cum laude, majoring in history with a minor in geography. Prior to medical training, Dr. Grabill served in the U.S. Army as an infantry officer, built and managed drug manufacturing plants, and built custom homes. Dr. Grabill graduated from the University of Kansas School of Medicine. He is a member of the American College of Surgeons, SAGES, American Foregut Society, and the Society for Surgery of the Alimentary Tract. For Dr. Grabill's clinical interests include general surgery, minimally invasive foregut surgery, and advanced endoscopy. Outside of the hospital, he enjoys spending time with his wife, exploring new restaurants, and attending live music venues. Please join me in welcoming Dr. Nathaniel Grabill.
Good morning. I've got two computers I got to operate up here, so excuse me if it's a little clunky. I'm excited to talk to you this morning about a topic that I'm very passionate about, global health and specifically global surgery. I've spent a lot of time in Haiti working on primary care access during medical school, after medical school, and actually during residency as well. This last fall, I had the privilege to do a global surgery rotation in Ethiopia and Malawi. Today I wanted to share with you some of my insights from these experiences, specifically why I think global surgery is important, why I think residents should get involved, and my ideas for how to integrate this into practice after residency. So I have nothing to disclose. Dr. Royal wanted me to warn you that some of the photos I'm going to show you are a little graphic, so be warned. Sorry, I advanced that too far. All right, so learning objectives. Today I wanted to give you some information about some critical things. So first of all, critical role of global surgery and global health. Hope you have a better idea of that when I'm done talking. Identify key benefits of global surgery rotations for general surgery residents. I want you to be able to understand the process for getting a global surgery rotation approved, and then my thoughts for strategies for integrating practice, global surgery into your clinical practice after residency. So what is global surgery? The Lancet Commission on Global Surgery defined it as a field dedicated to improving access to safe, affordable, and timely surgical care worldwide. So why is global surgery important? So first of all, the burden of surgical disease is great. Over 5 billion people lack access to safe, affordable surgical anesthesia care worldwide. Global mortality is a huge issue related to surgical disease. When the Lancet Commission was completed in 2015, they had estimated that in 2010, nearly 17 million people had lost their lives as a result of lack of surgical care. Sorry, need to advance that. Told you it was going to be a, oops. difficult operating two computers. So in 2010, the combined loss of life associated with lack of surgical care was more than the deaths associated with HIV, tuberculosis, and malaria combined. The surgical disease burden in itself is 30% of the global disease burden. So the total disease burden associated with surgical disease is great. So what is limited access to, so something's going on here, sorry. So limited access to global surgery is a big deal. And so I wanted to show you some aspects of, as I go through here, what these things look like. So what does limited access to global surgery look like? It looks like this. This is a gentleman I met on a trail in the mountains of eastern Haiti that I saw this fungating mass on his chin, and so I started talking to him about it. He had first noticed this mass is just, it started as a lesion, a scaly lesion about 20 years ago. He had tried several times to have, he sought medical care several times at local clinics, but they told him he needs surgical care to get taken care of. Didn't have the money to do so, and so 20 years later, he's got this mass that appeared to be invading his mandible. So another reason why global surgery is important is healthcare equity and access. Access to safe and affordable surgical care is poorest in low and middle income countries. Regardless of your reasoning for going into medicine, I think at the most basic level, our number one reason should be taking care of patients. This should apply to all patients, not just the patients that have insurance and can pay. So ethical responsibility, I believe it's our ethical responsibility to address this. The disparities that we face as a result of not having equitable access are huge. We're taught the principle of justice in medicine in medical school, and we're actually tested on that in ABSITE here. So the principle of justice emphasizes the fair distribution of healthcare resources and the moral obligation to reduce disparities. So another reason why global surgery is important. So what does unfair distribution of healthcare resources look like? So the picture here on your left, the first two pictures are of a typical operating room in Ethiopia, and the operating room corridor here, the second picture. Everyone can probably recognize the third picture. That's our OR6 upstairs and the operating corridor upstairs. There's quite a bit of difference, pretty visible between this picture and this picture as far as resources are concerned. So the economic benefits and the social impact of global surgery is another reason that it's important. The lack of timely surgical intervention can lead to chronic disability, reducing an individual's ability to work and support their family. Households in low and middle income countries often face catastrophic health care expenditures, pushing them into further poverty as a result of out-of-pocket costs for surgery. It's not unusual for patients to have to borrow money from extended family for surgery in low and middle income countries. The economic burden extends to communities and national economies, even with the loss of productivity and increased dependence. So what does disability due to lack of timely surgical care look like? This is an example. This is a man in his 20s that I met that when he was in his early teens had sustained this burn to his left shoulder. Wasn't able to get surgical care, and then the picture on the right, you can see that the wound is actually adhered to his chest. There's a stricture in his elbow. He's not able to use his elbow. He's only able to use the hand on the left side. This is something that could have easily been taken care of if he had access to proper surgical care. Moving on the importance of global surgery, the economic and social impact of global surgery is huge. The Lancet Commission estimated that the return on investment of up to $10 for every $1 spent on scaling up surgical services in low and middle income countries. The economic burden of untreated surgical conditions is substantial. And by 2030, there was estimated loss of $12.3 trillion to global GDP as a result of underfunding of surgical disease. This is by the Lancet Commission as well. Many essential surgery procedures only cost about $7 to $200 to avert a year of disability or shorten life from mortality, which I venture to say each of us spend $7 probably on Starbucks every day. So I was trying to give you an example of how cost-effective global surgery is. So I was trying to compare 2 days in the hospital in Malawi versus 2 days in the hospital here in the United States. The best data, easily accessible data for the United States I could find was as far as only in 2017, 2019. So I'm sure the cost is much greater today after COVID. But on the left, you see there 2 days in the hospital in Malawi. It cost about 3,000 Malawian kwacha, which is a monetary unit for each day in the hospital. It cost a patient 100,000 Malawian kwacha for an appendectomy, the surgical care and anesthesia. So about 106,000 kwacha, which is 61 US dollars in today's dollars. The same thing roughly here in the United States. In 2017 and 2019 cost well over $13,000. So surgical care is cost effective. In my mind, I'm sure today that here in the United States, that number is probably 30 or 40% more. So moving on to why residents should be involved in global surgery. I think there's some major benefits to that. First of all, professional and clinical development. The disease pathology you see in a global surgery rotation is unlike anything you'll see in the United States. You'll see late stage malignancies, congenital anomalies that we've never seen, tropical diseases. I didn't realize that TB could cause peritonitis until I went to Ethiopia. It also enhances your resourcefulness. Working in a low resource environment fosters adaptability, innovation, problem solving. It's amazing to go to an operating room in one of these countries. Residents are responsible for bringing everything into the room, and finding what you need to do a surgery is always a problem. When we show up in OR 6 upstairs, everything's lined out for us and ready to go. It's not that case in most of the world. So I think one of the benefits is making you think outside the box and be able to solve problems that you would not otherwise be able to. So examples of diverse pathology that I personally saw in Africa. On the left is the picture on the left there is of endemic Kaposi sarcoma. This is a 30-year-old, roughly 30-year-old that was on palliative care for Kaposi sarcoma that showed up in the hospital, unable to stop the bleeding on his foot, venous bleeding that I threw numerous stitches. I couldn't get it to stop. Eventually held pressure for several hours before we got it to stop. He had lost a couple units of blood by the time that was done. The picture in the middle is of an osteosarcoma of the sternum. Obviously been there for a long time. This patient only showed up because he couldn't stop bleeding as well. The picture on the right is of an obstructing squamous cell esophageal cancer. In the month that I spent in Malawi, I saw 9 patients between consults and follow-up in clinic that had obstructing esophageal cancers at presentation. And it's very prevalent also in Ethiopia. An example of resourcefulness, in the hospital I was at in Ethiopia, they had only been doing laparoscopic surgery for 2 or 3 months. So they, as you can imagine, reusable or disposable items in these countries are really difficult to come by, like suture and endo-catch bags. This is an example of them, how they take out the gallbladder in a cholecystectomy. They take a sterile glove, they tie off the fingers, cut off the fingers, and then they use the glove to remove the gallbladder. So other benefits for surgery residents, the professional and clinical development that's associated with it. I think cultural competency and interpersonal skills are something that are really important. If you do a global surgery rotation, you'll be exposed to different healthcare systems and how they manage it, different patient perspectives, and improving your ability to deal with diverse populations here, even in the United States. So I'm thinking of showing you an example of what it's like to manage cultural issues. I came up with these pictures here. The picture on the left is, so I mentioned earlier in Ethiopia, they had just started laparoscopic surgery. The residents didn't have very much experience with that. So the picture on the left is me teaching their second-year resident how to run a camera during the procedure. The second picture is me taking over the camera when the attending got frustrated with the camera use, as we have seen before. And the cultural competency part of it is I'm watching this attending dig below the Ruvier sulcus for 30 seconds or so before I felt like I had to say something. So finding an ability to say that you probably shouldn't be below Ruvier sulcus digging around and being able to say it in a manner that's non-offensive and respectful, I think is something that is something that you can learn from a global surgery rotation. After this operation, the attending and I were talking through the case, and he thanked me for the advice, and I was able to maintain my relationship with him even after, saying something that's difficult to do. This is something that we wouldn't typically be faced with in the United States. This episode gave me a better appreciation for our attendings and the anxiety that they feel when they see a junior resident digging around. So other benefits to surgery resident engagement are, learning about the ethical and social responsibility associated with this. I think residents can contribute to global health disparities by participating in global surgery initiatives. They don't have to necessarily be rotations, but you can get involved in a lot of different ways, even by advocacy. Getting involved in global surgery promotes advocacy for underserved populations. It also is a good networking and research and career development method. So professional connections, I met several surgeons, U.S. surgeons that I actually connected with after my rotation in Ethiopia specifically. One surgeon offered to help me get a job that he knew of, someone that was supporting surgeons in global surgery after residency. As far as research opportunities, they abound all over the place. If you're interested in writing papers, presenting at conferences, contributing to global health policy, there's numerous opportunities for that. And then opportunities to build leadership skill and advocacy skill in global health. There's no better place to find that. So, in a couple examples of my personal connections associated with global health and global surgery, the picture on the left is of a group of individuals that I still stay in almost weekly contact with. They're a primary care team in Haiti that I helped start in 2018. Great group of people. I count them as good friends today. The picture on the left, you know one of the guys. The other bald guy is someone you probably heard of but don't know. It's Dr. Paul Farmer, one of my medical heroes. In medical school, this guy founded a clinic in Haiti. Excuse me. There's now a major hospital in Haiti. He was the founder of Partners in Health. He had the audacity to propose treating HIV patients in low and middle income countries with highly active retroviral therapy when it was thought that was not possible to do due to cost. His advocacy changed the treatment of HIV in Haiti and in Africa and other places in the world. I was in the Port-au-Prince airport in line to go to the airport or get on the plane. When I turned around and a couple people back, I noticed Dr. Farmer. So I got out of the line and walked back and introduced myself. Very generous man, had a really nice conversation. I think he's the only guy I've ever asked to take a selfie with. In talking about leadership development in global surgery rotation, this is a picture of an attending and 2 residents and myself on day 2 in Malawi. I was the senior resident on call for the entire Malamulo Hospital with a team of 2 junior residents I had just met that morning and an attending that I had met the day before. There's nothing like such an experience to get you out of your comfort zone, stretch your clinical abilities, and develop leadership skills. So another reason, and I think I would argue is the most important reason that general surgery residents should get involved in global surgery is that I believe that you're more likely to participate in the long term if you are involved during medical school or residency. My hypothesis is that residents that take part in global surgery rotations are more likely to engage in global surgery as an attending. I think it's much harder to get started exploring an interest in global surgery as an attending for multiple reasons. All right, so how-to guide for global surgery rotation. How do you go about doing this? It's not easy, but it's doable. First of all, you need to decide where you want to go. If you're wanting to go to Africa or Central South America or Southeast Asia, it's probably going to be a broad general surgery experience. Likely you're going to have cases in OB-GYN, urology, orthopedics, a whole broad array of surgery. If you want to go to Europe or Australia, it's going to be like the United States from a technology standpoint, but you'll probably find different ways of managing patients. So I think the experience is valuable. Trying to give you an idea of what it's like to do a surgery rotation in Africa. The picture on the upper left is me and a resident reducing an orthopedic injury. I did many orthopedic cases in my rotation in Malawi. The picture on the lower left is of an ICU in Ethiopia, the typical ICU. It's a big room with a lot of beds. Doesn't look like our ICU in any manner at all. And the picture on the lower right is of a surgery resident on the floor draining fluid through the fontanelle of a child's fontanelle. The child had hydrocephalus, and they drained fluid, stuck a needle in through the fontanelle right on the floor and drained fluid. I was amazed. And then, doesn't seem to match, but the toilet paper in the upper right-hand corner is a commodity in Africa. No bathroom has toilet paper. So this bathroom had toilet paper, so I had to take a picture of it. So that's what you'll experience. You have to carry your own toilet paper. So how to go about it, you have to take the initiative. First of all, you can talk to your program director. You can talk to attendings with similar interest. Fortunately, I had Dr. Strom, who has been involved in global surgery, that was passionate about it and helped me out a lot. I know that Dr. Kuhn is interested in global surgery. I'm sure he can help as well. Talk to residents that have done it. I'm happy to help you figure out the steps to do this. Networking outside of residency, your residency program is helpful too. The rotation that I did in Ethiopia was as a result of a mentor that I had in Kansas that knew the medical director of the American College of Surgeons HOPE program. That's how I got to Ethiopia. I got to Malawi based on Dr. Strom's connections with Loma Linda University. I also did extensive search on the internet for sites that were ACGME and American Board of Surgery approved. So you have to have ACGME and American Board of Surgery approval to do these rotations. So the site, first of all, has to be approved. It's not just getting the resident approved, but the site first has to be approved, and then the resident has to be approved by both ACGME and American Board of Surgery. The supervising surgeon that you're going to work under has to be an American Board of Surgery boarded surgeon. This is really difficult. This is the most difficult portion of this whole, my whole experience. It took me 4 or 5 months of emails and calls to try to find a surgeon in Ethiopia that I could work under. Eventually wasn't able to find someone, and amazingly, the ACGME and ABS actually approved me to work under an Ethiopian surgeon. So there is, on this website, there's a very detailed list of things that you need to do to get both site and resident approval. It's a checklist. It's not, I mean, there are things that take some time to do, but it's very organized. I can share that with you later if you're interested. So other requirements to do this, you have to have the designated institutional official, the DIO's approval, obviously, to do this. Hospital leadership had to approve this. The rotation site obviously has to approve. They have to accept you. You have to have health and evacuation insurance. Most countries, you need to submit documents in order to be able to practice medicine there. I had to do that in Ethiopia, did not have to do that in Malawi. There has to be a PLA between our GME department and the site that you're going to. ACGME requires the program to pay your salary during these rotations. They have to pay travel expenses, health insurance, and evacuation insurance. You as a resident are responsible for all your other expenses, but the vast majority of them, the program is paying. So global surgery after residency, obviously I'm not after residency yet, but I have a lot of ideas about how to do this and read about it. So I wanted to talk to you a little bit about how to think about incorporating global surgery into your practice afterward. First, I'd like to just say something about sustainability. We could talk for the entire hour about sustainability, but I think it's important when it comes to doing medical work overseas and understanding what sustainability really means. So the Lancet Commission, again, that I've referred to, defines sustainability as design and implementation of surgical care that is continuously providing high quality, accessible, affordable services over the long term without depleting resources or relying indefinitely on external aid. And I think the most important part of that is relying on external aid. As surgeons from high-income countries, I feel it does little good to go complete a bunch of surgeries. Yes, you're helping some patients, and I think that's a good thing, but the real return on investment is in capacity and infrastructure building. So by capacity building, I mean training and empowering locals. So training surgery residents, training existing surgeons on different ways of doing surgery. Infrastructure development includes facilities, equipment, supply, change, that sort of thing. So what does sustainability look like? The picture on the right is a picture of the Malamula Adventist Hospital that I was at in Malawi. This place was established as an Adventist mission in 1902. They began providing medical care there in 1915, so they've been providing medical care for well over a century. They've been training health professionals for over 60 years. Now it's a major referral hospital with patients coming from all over Southeast Africa. We regularly had patients from Mozambique and Zimbabwe coming to Malawi to this hospital because of affordable care. This hospital is supported by Loma Linda University, their Global Health Initiative, and the Adventist Health International. This is what sustainability looks like. So career paths in global surgery. You could be a full-time global surgeon. The ones that I worked with, the 2 American surgeons I worked with in Malawi are in there full-time. Not all of us can do that or want to do that. There are obviously other ways of doing that. There are hybrid models for doing that, balancing local practice with periodic global health engagements. That's my plan, and I can talk to you more about that if you're interested, what my thoughts are there. There's a lot of academic surgeons, if you're going more of an academic path, that are involved in global surgery, more so than private practice surgeons. Those academic surgeons are conducting research or teaching, and they're developing surgical training programs abroad. So that's a possibility. Academic and institutional engagement can look different. You can do different things. It doesn't all have to be one template. You can collaborate with universities, hospitals, organizations that focus on global surgery, and I'll give you some examples of those here soon. You can be involved in mentorship and training, and I mentioned that before. I think training and mentoring next generation local surgeons is where sustainability is in the global surgery realm. You can be involved in policy and advocacy work. Many professional organizations are involved in global surgery. I've listed a couple here. General Surgery Foundation is a worldwide organization. The American College of Surgeons HOPE program is heavily involved in Africa. SAGES even has Global Surgery Initiative. You can be involved in policy development and helping expand global surgery care. Again, advocacy is important in global surgery. You can advocate for global care in being part of global health agenda. You can help develop global surgery in surgical education as well. So my next to final plug for training is, I think, above all other things, if you're going to be involved in global surgery, where we can contribute from a high-income country is in training. Training local surgery residents is the most sustainable, I think, and impactful way for surgeons for high-income countries to contribute. So, in conclusion, I wanted to encourage you, first of all, to do something. Situations and circumstances, especially in global health and global surgery, are changed by people that take action. In referencing people like Paul Farmer. So to review a little bit, surgical disease is a major solvable health crisis, and residents can contribute meaningfully. How you can be involved: you can do rotations, you can do research, you can be involved in mentorship in global surgery. You can seek fellowships and professional organizations that are involved. I had one example, not with surgery, but with just medicine in and of itself. In Malawi, they have a great pathology program. There's a pathologist in Minnesota that reads all their pathology. They have a on-site pathology tech that develops the slides, takes pictures of those slides, and we could get pathology results in 24 hours in Malawi, much faster than we can even in this hospital. So an example of something you can do without even going out of the United States. There's many organizations that are involved in global surgery that you can be involved with. G4 Alliance is a group of different organizations that are involved in providing surgical, obstetric, trauma, and anesthesia care worldwide. Incision is another nonprofit organization that's for residents, young doctors, nursing students and people early in their professional careers involved in global surgery. COSEXA, the College of Surgeons of Eastern, Central, and Southern Africa, is the African equivalent of American College of Surgeons. It's the largest surgical training institute in sub-Saharan Africa that you can actually be involved with. Operation Smile is another one. Everyone knows, maybe you don't know, but Elaine Lilly was heavily involved in this organization. They are a plastic surgery organization that goes around the world fixing cleft lip and palate. PACS I was at a residency in Malawi. That's a PACS residency. This is a Pan-African Academy of Christian Surgeons. They train surgeons, anesthesiologists, and OBGYNs in Africa. They have 21 different residencies in Africa in 12 different countries. So that's a good opportunity to be involved. Finally, I'd encourage you to start planning. Plan for your future practice, plan for a rotation, try to figure out how to do a general surgery rotation and how you can be involved in the future. And then my final thoughts, if you don't remember anything from this presentation, I hope you remember these two things, that I think residents who take part in global surgery rotations are more likely to engage in global surgery as attendings. And talking to numerous attendings that I met in Ethiopia and Africa, every single one of them had done something like that as a resident and as a medical student. And then finally, training is where it's at. Training local residents is the most sustainable, impactful way for surgeons from countries such as ours to contribute. Lastly, here's my references. Couple more pictures. Picture there on the left is of all the residents and attendings and I in Malawi. The one on the right is the coffee klatch that was every morning after handoff in Ethiopia. All the residents went out to this little place and had coffee, which is a great experience, just getting to know them. The middle one is, it wasn't all clinical activity. That's me on the highest, at the summit of the highest mountain in Malawi. So that's it. Questions can I answer?
Thank you so much, Dr. Grabill. If anybody has a question, please raise your hand and I'll bring the microphone to you. Any questions, comments? Okay.
Hey, Nate. Good presentation. Just a practical question, since these are approved by ACGME, are you able to log these cases and count them towards your training?
Yeah, that's one of the requirements, is you have to be able to log the cases. So that's the reason that they require you to work under an American Board of Surgery boarded surgeon.
Hey, Nate, thanks for your presentation. Amazing information, and really awesome that you're able to go do this and also bring awareness to it here. I think it's a really big deal, and I think that what you said about sustainability is the key, because a lot of people go to these intermittent clinics and they go and they do a good job and they provide care, but they miss out on the sustainability of when you leave, that place needs to be able to function and care for residents, and so that's really important. And I wanted to say, a lot of people are worried about language barriers when they, think about this kind of stuff. Can you give your experience with how you were able to be successful even in that setting?
Yeah, that's a very good question. First of all, I went to countries where they speak English a lot. So in Ethiopia, most everyone, especially in medicine, speaks English. Now, that being said, it was often hard to understand them, especially during handoff. I had to concentrate really hard when they were speaking fast to understand their English. In Malawi, again, that's a former British colony, so they widely speak English. But there, most of the patients did not speak English because it was a more indigent population. So they were used to having Loma Linda residents there, and so they actually had someone on staff that just followed me around and interpreted for me. So it was great. Yeah. But that is a good point. That can be that's something to think about when you are thinking about where to go.
Thank you. Any other questions or comments? Oh, sure.
I think this is great, and I'm glad we put the work into it, Nate. Thank you for, if you had to arrange an international rotation for a resident, Nate was the one to do it for, because he did 80% of the work, so I appreciated that so much, because, anyway, one of the things you can really do, especially with places that are involved in training, is, I think when you get into your practice, it's always a concern about time constraints. And especially since so many people are employed these days, I don't know how much vacation our tax surgeons officially get, but it's probably not England where you get 6 weeks a year. But you can do a lot to go for 2 weeks. When you're going a long ways, you need to go for 1 week is hardly long enough. Now, if you're going to Central America or somewhere, a week is okay. But when it takes you 2 days to get there, you kind of need to be gone for 2 weeks. But to think about, even if you're going to, for example, I'm actually hoping to go in September to in a hospital in Ethiopia, because it's a teaching hospital, but one of the weeks that I'm going to be there, the faculty are going to a conference on faculty development for the residency program. And so the people who are left at the hospital are going to be shorthanded. So I'm basically helping cover that week when they're shorthanded. So it's not something where you have to do a long-term thing. You can go, and if you have a specialty, go and teach them a little bit about your specialty, because these surgeons are doing general everything. And so, any little thing that you can bring them that's, whether it's vascular or colorectal or endoscopy or, laparoscopic or whatever it is, and just say, I'd like to teach you some, teach you stuff while I'm here. And most of them would say, please, because they're just kind of picking up what they can learn. So I think it's a great thing. I did this for 10 years, and every time the whole time I was operating in Bangladesh, I was going, gosh, I wish I had a 3 or 4 here, because they would just die to be here and get all this experience because of the great cases that you do. So it's really worth doing and very rewarding if you can incorporate it in your future practice. And one of the things you can do if you're not going to be employed but go places is tell people up front that this is what you want to do and negotiate some extra time off. When I came to Gainesville 30 years ago, I said that I need a month off every year to go to Bangladesh. And they wanted me enough that they said, okay.
Yeah, I think that's a very good point. I think simple things, and what I meant by hybrid involvement is that short-term aspect of going. There, in a lot of these places, like those PACS residencies, there are surgeons there that are on 24 hours a day, 7 days a week, 365. And for them to be able to go for even 2 weeks on vacation with their family is a big deal. So you can go there, you can teach residents for that period of time, you can supervise residents, you would be the attending surgeon for them during that period of time, allowing them to take some time off, which I think is a very useful aspect that you could be involved in and not have to affect your practice here at home very much.
Oh, we have a comment here, a question.
Thanks, Nate. Good presentation. I really like that you focused on sustainability too, because I think that piece with like globalization is really important. Can you talk about what you experienced since being back in terms of being able to be sustainable while being here? Meaning like WhatsApp connections, emailing back and forth, talking about cases, because that's been one of the more rewarding things personally, and then also makes it easier to go back again to the same spot because you are picking up where you left off and having some communication throughout the year or years apart from the space.
Yes, I think before I maybe answer your question, I think the most impactful thing that I noticed when I got back is going into surgery here and seeing all the stuff we throw away. It's absolutely amazing to me. We see it every day. We don't think much about it, but there they use everything again. There's nothing thrown away. Even, the anesthesia tubing, I watch the anesthesiologists throw all that stuff away every time that we have surgery here. They reuse those and reuse those and reuse those. We're really, I think we waste a lot, and it's unfortunate. As far as being involved long-term, I'm still, in fact, I'm helping a couple residents and an attending in, actually Menon and I are helping a resident and attending in Ethiopia publish a paper. So they looked at all the data, they had all the data, and we wrote the paper for them. And because it's difficult if English is not your first language, it's really difficult to write a paper. So they gave us a paper that they had drafted, and it was terrible from an English grammar perspective. So we rewrote most of the paper. So it's very helpful to them and then another resident while I was there was applying for a fellowship, and he wanted me to review his application, and I helped him just with the grammar aspects of English. So from a sustainability standpoint and connection with them, I talk to them on WhatsApp all the time. I still talk to people from Malawi every day, almost every day, on WhatsApp. The connections here, when I left Malawi, my thought is to find a place to be able to go back on a regular basis as an attending. I talked to the attending surgeons there about it before I left, and they were falling all over themselves to have someone come back and spell them for a period of time. So I expect to go back there. 2 days ago I talked to Dr. Royal about it, and he said he would support it. So I want to go back next year to Malawi. I think it's that sustainability, that being able to go back over and over again. It gives you credibility in country as well. They've seen you before, they know you, you know them. That whole first week or two of getting to know each other is not the same, I'm sure, the second time you go back. I don't know, does that answer your question?
Just really quick, do you think it'd be possible to set up, a formal pipeline for them to send us papers and stuff to look over and edit and kind of keep that going?
That's tough, and I didn't expect how tough it was. So we're trying to do this, but there's data I didn't realize is very hard. It's very hard to share data. So there's lots of rules around sharing medical data. So for example, in Ethiopia, there's a whole law with imprisonment associated with it for sharing improper medical data. I didn't know that until until I actually was talking to the tax research group about doing a paper that we're talking about. They had done a a retrospective on small bowel obstruction in their hospital. I thought it would be interesting because they had a service that was very akin to our tax service here. Thought it would be interesting to compare the two, our experience with SBO and theirs. It's really difficult to get that done from a legal perspective. Once you get it set up, it'd be great. And I think it would be, lots of universities have got that set up and they can do that. It'd be wonderful because they have all kinds of stuff that they had a whole series on esophageal cancer, a whole bunch of data on local esophageal cancer that we could publish on. So that's an ongoing thing that we should absolutely do.
Awesome.
How do we get a global surgery program in our hospital?
Could you say that in here so that people online can hear you too?
Yeah, how do we get funding, administrative support, and hospital level support for global surgery program in our hospital? And who's done that well recently?
I'm not sure exactly how to answer that. I think we continue to advocate for it. We continue to ask for it and continue to do it. The more times we ask for it, it becomes more norm at that point. I know that there are programs that do regular rotations. I mean, the Loma Linda University, their general surgery residents, they all have an opportunity their fourth year to go to Malamulo Adventist Hospital and do a 2-month rotation. So that's just part of their curriculum. So there's no reason, I don't think, it's not that expensive. Ultimately, yeah, I understand that, any month that we're not here in the hospital, it costs the hospital money, but it's honestly, compared to the other things that you see spent, it's very small amount of money, ultimately. I think it just takes the will. for someone to stand up and say, hey, we're going to do it. And it takes advocates like you.
Thank you so much, everybody. Thank you, Dr. Grabill. This was a very inspiring presentation. Thank you so much.